I am LaToyia Jackson, and this is
Katrina Chan. How you guys doing today?
good. So perfect. I love it. Okay, this presentation is going to provide a high-level overview of the condition known as post-traumatic stress disorder, or PTSD. PTSD, according to the DSM-5, is classified as a trauma and stress-related disorder. We will be conducting a breakdown of the clinical indicators in accordance with the DSM-5 and ICD-11, current information about its prevalence and incidences, a summary of assessments, known causes of the disorder, and a typical prognosis. All right, so some symptoms of PTSD include anger and irritability, discomfort in crowds, can have some trust issues, startle response, numbing and avoidance, traumatic reminders, sleep problems, and trouble concentrating. Now, those who develop PTSD may have symptoms that may be more apparent, like in stressful situations or clinical settings. So it's important, like when we see people who are irritable or just generally any of these symptoms, that we treat them with courtesy and respect. So in America, we primarily use the DSM-5 to diagnose mental health disorders. And according to the DSM-5, we have the following indicators for PTSD: exposure to actual or threatened death, serious injury, or sexual violence. There are intrusions, avoidance, changes in cognitions and mood, arousal, and reactivity. The duration of the symptoms have to last more than 1 month, and they have to be clinically significant distress or causing some kind of impairment or dysfunction. And it has to be due to an event and not just due to like a physiological symptom or any kind of substance abuse or a medical condition. The rest of the world uses the ICD-11 to classify mental health disorders. And those indicators would be exposure to an extremely threatening or horrific event, re-experiencing, which is like you were going through the event more than one time, avoidance of things that remind you of the event, persistent perceptions of heightened current threat. So it's like a hyper arousal. For them, according to the ICD-11, these symptoms must last for several weeks, and you have to have significant impairment in personal, family, social, educational, occupational, or other areas of functioning. Now, I'm going to expound on these in the next 2 slides. All right, so the Diagnostic and Statistical Manual of Mental Disorders, which I described as the manual that we use here in America. Here you can see a little bit more detail about what intrusive thoughts are, which is one of the indicators that I mentioned before, which so we're going to have repetitive unwanted memories of the event. Second indicator is going to be avoidance. So you're going to like resist conversations about that topic. It could be smells, any kind of trigger that reminds you of that event. They experience heightened arousal. So you can describe that as being hypervigilant, like always looking out for danger, always scanning your surroundings. And they also have trouble falling asleep. So there's a lot of sleep problems too that can develop as a result of PTSD. Changes in thoughts and feelings. That's probably more along the lines of the depressed side of it, where you lose interest in things that you once enjoyed. And some important factors to remember according to the DSM is that the symptoms have to have lasted for more than 1 month, and it has to have caused significant distress or impairment. And another important factor is that it's not caused by any other substance or medical condition. All right, so we're going to look at the International Classification of Diseases, the 11th edition, also called the ICD-11. All right, so important thing to note is that in the ICD-11, which is the updated version of the ICD, they have added complex PTSD as a diagnosis, which is drastically different from the DSM, because in the DSM, we only have the regular PTSD diagnosis. So just wanted to kind of highlight that on this slide. There are additional indicators that they use for complex PTSD, but for the purposes of this presentation, I'll just kind of describe the regular PTSD condition. So with the ICD-11, you're going to have a sense of threat, which is the hypervigilance, like we described in the DSM. There is the avoidance of any kind of triggers that would remind you of that event. And also, you would have re-experiencing of the traumatic memories, and they are also intrusive thoughts, the unwanted thoughts. Okay, according to the ICD, the symptoms should last for at least several weeks, and they're going to cause significant impairment in many areas that I mentioned before, like work, social functioning, etc. All right, so let's go over some of the epidemiology, how prevalent PTSD is. So approximately 1 in 11 of people in the US will be diagnosed with PTSD in their lifetime. That is an outstanding number. So just wanted to put that out there. It affects about 3.5% of the US population each year. And the lifetime prevalence of PTSD is about 6.8% in general. In men, the number over the lifetime is about 3.6%, and in women, it's almost triple that at 9.7%. Women are twice as likely to have PTSD at some points in their lives, and that is usually due to, honestly, rape or situations like that. Children and adolescents rates of PTSD can vary, and some studies show that prevalence of PTSD in children who are actually exposed to a traumatic event might be higher than in the general population, but there really are no particular studies that have been able to track these specific percentages. And as far as worldwide, the statistics vary. They can range anywhere from 0.3% in some countries up to 6%, but the methodologies are vastly different than what we use, and the indicators are different. So it's really hard to compare those diagnoses and to get a good percentage. So PTSD in veterans, so prevalence among the military population and veterans is much higher than in the general population. It is estimated that the lifetime prevalence is 30% among service members in men, and then 26.9% in women. And several studies conducted to determine the prevalence amongst different wartime periods for veterans, okay? In the Vietnam War, they found that 30% of the active veterans had developed PTSD. In the Gulf War, about 10% developed PTSD. Operation Iraqi Freedom, 20% developed PTSD. And in the war in Afghanistan, about 11%. So those are very high numbers, especially when you consider that 6.8 of the total population, the general population, experiences PTSD, and then you have numbers like these. It's so much higher in veterans. So that is definitely an area of concern, and we need to address that with curiosity. As far as assessment, so once we get all the symptoms and we're looking at the patients, how do we assess a person for PTSD? Well, there is actually no one best assessment necessarily. It kind of depends on the clinician and whether or not they need a quick screening, or if the kind of what the goal is. Like if you're doing like a clinical interview for someone or a trial study, then you might want to do a longer format. The CAPS-5 is the kind of gold standard for PTSD assessment, and that stands for the Clinician Administered PTSD Scale for the DSM. And this is mainly, you use this as a 30-item structured interview, and it is used to make a current diagnosis of PTSD, or make a lifetime diagnosis of PTSD, and assess PTSD symptoms over the past week. So this is kind of what you're going to go to assess. It's like a baseline. There are also several resources, several assessments on the National Center for PTSD. And they also provide training on how to administer the CAPS-5. So some good resources. How do we treat a patient who has PTSD? Well, cognitive behavioral therapy, or CBT, has been proven to be the most effective evidence-based treatment. Two forms of CBT include that are primarily used to treat PTSD are cognitive processing therapy. And that form of therapy, the clinician is going to focus on modifying painful negative emotions such as shame and guilt, and beliefs such as I failed and the world is dangerous. They're going to help the person confront those distressing memories and emotions. Prolonged exposure therapy, it's going to use repeated and detailed imaging of the trauma and progressive exposures in a safe environment and in a controlled way. And it kind of helps the person gain control of their fear and distress by allowing them to re-experience like the battlefield over time in a controlled, of course, therapeutic way. Group therapy also helps with PTSD. That encourages survivors to talk about their experience with people who have also experienced the same events. And so it gives them a sense of camaraderie with knowing that they're not alone. This is also led by a clinician who also administers CBT. So EMDR is eye movement desensitization and reprocessing. So in this, a trained clinician is going to basically help clients activate their natural healing processes in the brain. So they might have a client think about a traumatic event. Again, it's standard procedures and protocols that they use to help those eye movements desensitize their brain and rewire and restructure those connections. And that has been proven to alleviate the symptoms of PTSD. So it's a very good non-medical treatment, non-medicine. So some proven medications that have been effective in treating PTSD are antidepressants such as SSRIs and SNRIs. Some common examples are Prozac, sertraline, that are known as Zoloft, Paxil, and Effexor, just to name a few.
Now we're going to talk a little bit more about the etiology of PTSD. So PTSD can occur at any time after a traumatic event. It can be immediately right after, or it can take up to 6 months for it to develop. And according to Neura, the age does not exactly have a direct reflection with PTSD symptoms, as is stated before. Age and gender, they do have some correlation, but there's no definitive research about that. And the actual cause for PTSD is still unknown. Some cases, they believe it might be related to the temperament of the person in the situation, or just how the body itself reacts to stress and develops their hormones. But exposure to traumatic events can increase the likelihood of PTSD developing, but the predispositions might be necessary in most cases for the symptoms to develop. So the etiology continued. PTSD is often associated with traumatic events that a person believes might be their fault. So for example, a death of a family member, car accidents, sexual assaults, pregnancy, or as we stated before, military combat situations. And this is often seen, and it's not a comprehensive list, but first responders, victims of sexual assault, kids growing up in abusive households where they might have been sexually assaulted or part of a domestic violence situation, or like I said, military personnel. So the hippocampus, amygdala, and the prefrontal cortex is the parts of the brain that is usually affected and altered in people that have PTSD. Those people have either have all of these or a combination of these of an underactive hippocampus, an overstimulated amygdala, and a hyperactive prefrontal cortex. So it is important to note that there is not a definitive cause to PTSD, but there are situations that places a person higher risk for PTSD. According to the National Institute of Mental Health, risk factors can cause for a person to develop PTSD. Risk factors include prior trauma, a lack of support, brain injury, life stressors, pre-existing conditions, traumatic experiences, and even genetics. However, not everyone who's been through the same situation or even will develop the same form of PTSD. As we saw with the DSM-5, we talk about PTSD itself, but ICD does have complex PTSD as well. You can develop PTSD without forming complex PTSD. However, biological and chemical makeup of an individual can affect the traumatic experience that the individual is exposed to. We see this in a study clarifying the origins of biological anomalies in PTSD through the study of identical twins. One twin was in combat, the other twin was not. And Gitterson had conducted this study, and he stated that combat exposed twins with PTSD shows higher HRRs than their own identical combat unexposed co-twin. And while there's still questions concerning this etiology, the risk factors, and the reason why some people have PTSD and others do not, researchers are still moving forward to try to find a better treatment and better pre-treatment options. So we're talking about the cognitive and the biological effects of PTSD. PTSD doesn't just affect the emotional side of things. It does affect brain chemistry. It does affect the cognitive and biological parts of your body. And people who have been diagnosed with PTSD have damage to their prefrontal cortex, hippocampus, and amygdala, just like I said prior. And these parts of the brain can affect abstract thinking, their personality, decision making, even memorizing things and relearning information. And there have been studies where working memory of a person is affected due to the damage in their brain. But I'll be breaking down these three primary brain regions that are affected by PTSD. So the prefrontal cortex mainly focuses on abstract thinking. Amygdala is decision making and the emotional concept of things, and the hippocampus is memory consolidation and relearning things. So one example that I was researching by Hayes, it's the emotion and cognitive interactions in PTSD. PTSD involves alterations to cognitive processes such as memory, attention, planning, and problem solving, with an underscore of detrimental impact that has negative emotionally has a cognitive functions. So for example, when a military personnel comes back from overseas tours and a loved one notices that they're acting differently than before, it can be explained by the trauma that they have experienced or they have heard about, and they can have secondary trauma. And this later speaks about the social effects that PTSD has on certain individuals. So over here, we're talking about the prefrontal cortex. And in a PTSD brain, the prefrontal cortex is constantly in high gear, it's constantly working. And an individual who does not have PTSD, the prefrontal cortex helps to regulate mood, thought processes, and behavior. Normal activities that neurotypicals might think they're aroused by when they need to be aroused. And once they're not aroused, the brain kind of just is able to settle down and process through the information. As seen with the study by Arnstein, normal responses will equate to an equal reaction. But those with PTSD, normal everyday events can be perceived as a threat and an inability to put the brakes on, as I say in quotes, on the threat. The epinephrine from the adrenal medulla is identified as a hallmarker of acute stress, which is accompanied by the non-adrenal release from the locus coeruleus, which can be translated to long-term PTSD symptoms, according to Geralt. This can also be seen on Independence Day, where fireworks are going off and it triggers a veteran to duck and cover at the sound that reminds them of mortars going off. And this can also be seen in situations where getting into a car is difficult from someone who's been in a car crash and may have seen their entire family pass away. Normal events, fireworks, and car accidents, or going into a car, they're normal everyday events for us, but for people who have PTSD related to those events, it's difficult for them to overcome. So the prefrontal cortex, like I said, is not the only part of the brain that is affected by PTSD. The amygdala is also hyperactive, which means it's working in overdrive. This part of the brain is in charge of inhibiting fear-related behaviors, and people with an overactive amygdala may be in constant fight or flight situation. There is no break or slowdown to their central nervous system. However, because the amygdala is hyperactive, this can later lead to chronic stress, extreme sense of heightened fear, and even increased irritation. Because of this, hyperactiveness, anxious thought patterns, like we talked about before, may occur. Sleepings may have problems, and there may be no ability to calm the mind down from any situation. This can be seen with adults who either need to have a nightlight or sleep in the day and stay awake at night, or even an individual snapping at their family members over a small issue. According to Murray, there is a running theory that the smaller amygdala has a physical effect from PTSD on the brain that makes people with a smaller amygdala more vulnerable to developing PTSD. However, this is kind of a chicken and the egg situation because we're not sure if PTSD is triggered by a smaller amygdala or if the amygdala shrank due to PTSD as a side effect. So right now they're still trying to figure out which comes to where. However, there is information that cortisol is an important hormone that deals with metabolism and stress, and this levels typically lead to an increased amygdala volume. So again, there's still split cases on if this was a side effect of PTSD or this caused PTSD. So over here with the hippocampus, people usually have a underactive hippocampus, and in very severe cases of PTSD, a smaller hippocampus. And this part of the brain holds on to the memory formations and helps to form new memories and associations with the surroundings. This helps with place association and determines how to properly react into a situation depending on the stimuli. So I'll talk about it from a little nerdy standpoint is Batman. You know, our all-time favorite superhero without any superpowers. He has flashbacks from him witnessing his parents' death in the alleyway. And through the cinematic recollection, we can see he has moments where he's on pause being Bruce Wayne, not Batman. And all of a sudden, he's remembering his parents' death, them getting shot in the alleyway, him recalling the events. And this is triggered by damage to the hippocampus. And people with PTSD have difficulties determining a safe event from something that is in the past that's harmful to them. So when their mind is at a quote unquote rest stage, these memories start filling in the gaps and they start remembering things from the past, and it can dissociate them and disorient them in a way where they may be in a physically safe location, but their mind and their memories are coming in and reminding them of things that happened. So I'll talk a little bit more PTSD brain scan versus a normal brain scan. So over here is a picture of an MRI. The one on the right is considered the healthy brain. The one on the left is someone who has PTSD. So activity with red and white are more active parts of the brain. The blue is what's standard, typical, normal, what a normal brain would look like. And we see that in the right-hand corner, the red and the white is mainly in the cerebellum. This is what a normal person's brain should look like in theory. This helps with posture, our tone of voice, and helps maintain our balance, just everyday movement and basic human functions. And you can see the cerebellum is pretty active on the right-hand side, but in the left-hand scan, there's a slightly decreased activity in the cerebellum and more increased levels to the middle and the top of the brain, which is our more emotional centers, you know, the amygdala, the hippocampus, and the prefrontal cortex. And this is often why we see people with PTSD seeming withdrawn from society or even cold when they're talking to you, is their cerebellum might not be as active and help them navigate the everyday world. So this is a second picture of an MRI. It's a little bit more clear. You can see the activity levels within the center of the brain on the left-hand side with the PTSD. They do have a lot of brain activity going on compared to someone who doesn't have PTSD. The brain, you can see, is going into an overdrive situation. There is no brake system for the brain and for the emotions to process things. And that's one of the reasons why there's an occurrence in memory flashbacks. I'm not a medical doctor, so I hope I explained how MRIs and how MRIs work with PTSD. So additional information, this is coming from Dr. Bremer, who is a medical doctor on the study Traumatic Stress Effects on the Brain. He did a study conducted on Vietnam veterans with PTSD. As we mentioned in the slides before, 30% of Vietnam vets did have PTSD. But their brains were scanned using an MRI, and he saw the hippocampal volume was about 8% smaller on the right-hand side. But then he checks on the left-hand side of the hippocampus, and there's about a 12% reduction in volume. So these patients who have experienced PTSD and there was noticeable things going on in their brain, um, with reductions and whatnot. The noticeable thing is the atrophy and the memory problems with the hippocampus, but they were able to use SSRIs to almost revert um, the deficiencies, and it even allowed for neurogenesis to take place. So all this saying, PTSD can be reversed in some way, shape, or form, but it may not be to how their brain used to be prior to the event. It can come close, but there isn't a way to get them back to 100%. So the social effects, like I mentioned before, does have an effect on people who have PTSD. People with PTSD typically have heightened emotions, anger, grief, sadness, loneliness, but they're also at very extremes. And due to the effects on the limbic systems, they can be volatile or they might just be numb to the world. Many times, people with PTSD tend to feel like they're an outsider to their family and they're strangers in their own home. They tend to be withdrawn to society because they can't associate with people or even empathize due to the brain damage that has happened in their own mind. According to the Phoenix Australia's article on efforts of trauma on family, social, and work life, a person may withdraw from family and friends, stops attending social activities, becomes overprotective, or has difficulty expressing or managing emotions. And according to the Veterans Affairs article on PTSD, it also states that trauma survivors with PTSD may have trouble with their close family relationships or friendships, and the symptoms of PTSD can cause problems with trust, closeness, communication, and problem solving. So if you know someone who has PTSD, be kind to them, love on them, and just understand that they may not be the same person that you knew before the trauma, but they're still someone that you have to love. So, with all that in mind, I'm going to recap the developmental of PTSD. To start off, it usually starts off with a pre-existing condition. This can be environmental, this can be genetic, this can be something that's happening in your life as a life stressor that causes you to be either mentally fatigued, stressed out, what may it be. Then you experience the traumatic event, or in some cases, multiple traumatic events. Then it leads to a buildup in the fear of the event, which later can be expressed into a PTSD reaction, which is the avoidance that we're talking about. So all of this combined together, the genetics, the mental, the emotional, everything comes into play when talking about PTSD and mental health. So we're going to talk a little bit about the prognosis and the question of the day. How can we help someone who has experienced trauma or PTSD? And how long does PTSD last for? Well, for the prognosis, PTSD usually lasts for 3 years on average for those who've been treated. This is not to say that they have been completely cured and their brains are back to normal and back to when they were in high school before all the trauma happened. There may be more of a baseline to be able to feel more normal and more of themselves again. However, if it's left untreated, these severe cases can last for 5 years or even more. These are just averages. This doesn't reflect every person because there's different types of PTSD, CPTSD, what may it be. And there may be some other underlying issue that a person is dealing with, such as like depression, anxiety, schizophrenia, bipolar disorder, that is compounded underneath the PTSD, which makes it a little bit harder to treat. As one can imagine, if a person who's been diagnosed with other comorbidities, PTSD portion will be increasingly difficult to treat. In addition, if a person is continuing to have traumatic experiences throughout their life, for example, they are getting sexually assaulted and they've worked through that aspect of their life, but then it happens again, or say that they're in a narcissistic relationship or even a domestic abuse situation, they're not given the opportunity to fully heal from their experiences, and the symptoms of PTSD will continue to linger on. And according to Grayage, most PTSD sufferers report significant improvement in severity of their PTSD symptoms. As we talked about it in the beginning of the slides, most of the time they are going to be healed. They're going to be able to live their lives fully and be able to be what we consider a normal person of society. But however, According to his research, a third of them never fully recovered, even with treatment. This is not saying that the severity is still the same. They might still be suffering on just a lower level. However, the bounds of trauma is not something that can magically disappear in the blink of an eye. Even with help, support from family, friends, treatment, medication, PTSD may still be a lifelong battle. And the severity of the symptoms may lessen over time. The reactions may be better managed, and socializing within the community may be more normal and enjoyable. But that's all up to the person, and that's just based on their hormones. And each person is different throughout their journey with PTSD. Anyway, I hope that you enjoyed the slide. Here are some of our references. And thank you for listening to our section of PTSD. Have a great day, everybody.
Thank you guys. Bye.